Vertical ridge augmentation is actually the ability to create bone in a vertical direction after enormous bone loss that can be caused of multiple infections, advanced periodontal disease, or implant failures. The vertical ridge augmentation can be done in the posterior mandible, either from one side or from two sides at the same time. And one of the most trickiest and most difficult areas to treat vertically is the posterior mandible. It can be done also in the anterior mandible. Each area has its different specificities. It can be done also in the anterior maxilla. Here the aesthetic outcome is very important. We have to know where we will, which part we will reach before we start. Many techniques actually do create bone in the vertical direction. One of them was the bone distraction. The bone distraction is a technique that consists of actually separating the upper and the lower part of the bone in the area to regenerate, separated completely with piezosurgery. We open a buccal flap, we keep the lingual flap. We used to join those two separated parts completely with this device, which is a distraction device. We closed the flap. We kept actually a small screw out of the gum, and the patient, we used to give him a screwdriver. Each day, the patient used to turn it to put the two pieces of bone more and more away from each other to create more bone. But this technique nowadays is practically abandoned because it had a high risk of failures, of complication also. Another technique, it is the only block graft, or also known as the Hooley technique. It consists also of removing many only blocks, sometimes from one or more donor sides, to place them to create like a small box or room, and in which we used to place bone particles. It can be done for mild vertical ridge augmentation, but not for important ones. And personally, I think it is a little bit traumatic, as you have to remove bone from many donor sites. In Germany, where actually this technique was established, the majority of the patients are sedated or in the hospital. In our clinic, I find it a little bit difficult to do. And there is also the guided bone regeneration, which is the most used technique nowadays to create vertically bone, and it is actually the technique that has the most publications around it. The technique consists actually of using non-resorbable titanium reinforced membranes, PTFE, polytetrafluoroethylene membranes. It consists also of fixing the membranes from the lingual and from the buccal sides. It has to be completely rigid and immobile. We use also a mix of bone, which is a mix between autogenous and bovine bone. And we have to keep everything covered, non-exposed. Nobody has to touch the area for 9 months. Then we place the implant after that. Blanca and Urban, in a publication in the International Journal of Periodontics and Restorative Dentistry in 2018, they established like a decision tree to choose which technique to which indication. And actually they divided the indication into small bone regeneration needed, mild, medium, between 4 and 6 millimeters, and large, more than 6 millimeters of vertical regeneration are needed. Whenever it is small, less than 4 millimeters, we can do GBR, we can do only graft. And with the GBR, it is always staged, so we don't place the implant while doing the regeneration. We do the regeneration, then the implant is placed later on. With the small, we can use a non-resorbable membrane or a resorbable one. When we use a resorbable one, we have to use tenting screws. For the mild, medium, between 4 and 6 millimeters, also have to do GBR, treated like the mild one. And we can do the onlay graft. Here it becomes unpredictable. Between 4 and 6, the onlay block graft becomes unpredictable. When it is large, more than 6 millimeters, the GBR, it's always staged, and it is only the non-resorbable membrane. Okay, no membranes, no absorbable membranes used at this stage. And the onlay graft is unpredictable. What are the success conditions? 3. The choice of materials, the stability of the graft, and the complete coverage during healing period, which goes up to 9 months, not 6 months, not 8, but 9. Choice of materials. It has always to be a mix of autogenous bone and bovine bone. Why? Autogenous bone because we need osteoinduction. Osteoinduction is the ability to create bone from within the graft, from within the particles. Whenever we use autogenous bone, we have living cells that can create bone from within the graft. We need bovine bone because it is osteoconductive. Osteoconductive is the ability to help the migration and movement of blood cells and bone cells from the recipient side towards the graft. And why bovine bone and not allogenic bone? Because bovine bone has the ability to stay intact for many years to come. Actually, a lot of studies showed that bovine bone, 30% of the bovine bone stayed in place for at least 5 or 6 years or 7 years after. And this advantage gave this procedure a higher success rates, because before, when we used to use only autogenous bone when doing vertical regeneration, we used to lose at least 50% of the graft later on. The bovine bone now keeps the volume intact, and we only lose 1 millimeter, like I will show you. Non-absorbable membrane, why? Because the absorbable membrane actually stays intact for 6 weeks. For this procedure, we need a membrane intact for at least 6 months. So always non-resorbable membrane and reinforced with titanium to keep the volume. And we need also fixation devices. Fixation devices from the buccal and from the lingual. We need the graft to stay immobile and hard. Nothing can lose the graft towards all the healing period. The stability of the graft, the membrane must stay intact for a minimum of 6 months, like I told you. So non-resorbable membrane, and the graft must be immobile during this time. So fixing the membrane is crucial from the buccal and from the lingual. And I will show you how to do it. The graft must stay completely covered during the healing period. Early exposure means loss of the totality of the graft. If you do the surgery, some weeks after, maybe 1 or 2 months after you have an exposure, 90% everything is lost. If you have a late exposure, after 6 months, you have a partial loss of the graft. To decrease the chance of having exposure, it is crucial how to displace the lingual and the buccal flap. Some years ago, when this technique actually was explained by Bini Prato, maybe 20 years ago, they didn't know how to do the displacement of the lingual flap, and this is why they had a high rate of exposure. Now with the displacement of the lingual flap that can go up to 12 or 13 millimeters, the exposure rate is really lower. Also, one of the most trickiest things is the stabilization of the graft when doing posterior vertical ridge augmentation from the lingual part. It is really tricky. It takes a lot of time and a lot of effort, because you have to have at least 6 surgical hands inside the mouth of the patient. You have to do reflection of the cheek, of the buccal flap. Somebody has to do suction. They have to, somebody has to hold the gum from the lingual, somebody has to hold the tongue, and somebody must hold the tack, and somebody must hold the mallet. First case, patient referred to me for infection in the lower mandible. Do not take a look on the sinus, what's happened there, because it's not our problem for today. Probably the old dentist placed, I don't know, this is like a healing abutment inside the sinus. But the problem is here. It's this big infection around those two anterior implants. Of course, we must always take a para-apical X-ray to be sure of what's happening, a complete bone loss on the implant and on the adjacent teeth. In those cases, always we have to go staged, never do everything at the same time. Removing the implant, placing the implant, doing the bone grafting, it will never work. Always you have to do it step by step. So first thing to do, removal of the implants and the two adjacent teeth. Placing of a hard temporary. This is an acrylic temporary but reinforced with metal because we know that it will stay in place for a year. This is after 6 weeks. You can see how much bone loss we have after the removal of the two implants. Actually, the two implants went by themselves. I didn't make efforts to remove them. This is after 6 weeks. The flap is done. Crestal incision, two vertical incision, two teeth away from each side. You can actually here see that we need 7 millimeters of lingual vertical regeneration and we need 14 millimeters of buccal vertical regeneration. Preparation of the bone, removal of all soft tissue, making those small perforations to increase the blood flow coming out from inside the bone towards the graft. Trimming the membrane. This is a cytoplast membrane reinforced with titanium. The old generation of membrane are not perforated. I'm perforating them myself. Now the new generation, they are perforated. Why perforated? Because this increases actually the blood flow coming from the periosteum, from the periost of the flap towards the bone, and actually it increases the attachment of the flap on the membrane and reduces the risk of exposure. The mix of bone, 50-50 or 60-40 between autogenous and bovine bone, fixing the membrane from the lingual, which is also tricky in this area. Imagine entering from inside to fix the membrane between the tongue and the teeth, placing the bone, fixing the membrane from the buccal with many screws or tacks, whatever you have, suturing everything, a combination of separate sutures and horizontal matrix sutures. Placing back the temporary, removing 2 millimeters of the temporary because we have to know that after the surgery we will have a swelling and the gum will go up maybe 2 millimeters for the coming weeks after the surgery. If the temporaries are too close, they might open the flap. So remove as much as you can. Waiting for 9 months, removing the screws and actually seeing what happened. We have a very good quantity and very good quality of bone. Why very good quality? You can see how much blood is coming out from inside the bone. This is living bone. We created practically everything we lost. So this was the case before and this is after. This is another view and those are the two implants in place on 32 and 42. That's another case of a patient that actually came to me without any reference, just came to me and he told me that he has been like 4 or 5 years going from one dentist to another, seeing if there is any possibility to place something fixed on the posterior lower mandible. And actually the answer was always that we do not have bone to place implants. I actually proposed to him the vertical regeneration. If he is okay, we can try it, we can do it, and if it works, he will have his implants and he will have a fixed prosthesis. So the surgery was done from both sides. Actually, I did it on 2 consecutive days. One day on the left side and the other day on the right side. And always the closure, it must be really good. Waiting for 9 months. This X-ray was taken after 9 months from surgery. And we can see that in exact position, 19 millimeters from here, on number 36, here we had 5.9, now we have 10.2, so we gained 5 millimeters vertically. In the area of 37, we had 6. Now we had 10.9, like 11 millimeters. On the right side, in the area of 45, we had 5.9, now we have 8.8, 6.3, and etc. So we gained between 4 and 6 millimeters vertically. The flap was reopened 9 months after the membrane was removed. You can admire the quantity of bone that we gained. The membrane was removed, and the 4 implants were placed on the left side. Also, we had to extract the canine. This is the right side. You can see that all the bone from here to here, this is regenerated new bone. The old bone is now. You can see the demarcation line between the two. The implants are placed in ideal position. 4 implants on the left side and 3 implants on the right side, and these are the final restorations. Everything is screwed, and everybody is happy. That's another patient, periodontal disease, referred to me to periodontal treatment. The periodontal treatment was done. The indication here was to extract the smaller and to place implants. Unfortunately, the CBCT here showed us only 3 millimeters of bone width. The indication in this case is to do bone splitting. The bone splitting was done in perfect conditions, like we do it always. And this is the x-ray after that. Unfortunately, the patient actually called me 1 week after, saying that he had a lot of pain. I said 1 week after, maybe it is something related to the surgery. I told him to continue antibiotics, to take anti-inflammatory. But 2 weeks after, he told me that he had the same, so he came to me. And what I saw is this catastrophe. The gum was opened, the bone was visible, and I really didn't understand what happened here. I do this procedure maybe hundreds of times, and I never had this. What actually here I didn't know that this patient used to smoke 4 packets of cigarettes per day, and before starting surgery, he told me that he would stop. And he told me he would stop. I told him because we had a lot of bone grafting to do. And after what happened here, he told me, "Doc, I lied to you, I didn't stop." So I can only explain what happened here because of smoking. So, a big catastrophe. We had to remove 3 implants. And you can see the bone loss that happened. So all the bone that we splitted is gone. Now we need to do vertical regeneration. There is no bone vertically anymore. And we have now 12 millimeters of vertical tissue height loss. So we were only needing lateral, now we need lateral and vertical. Crestal incision, 2 vertical incisions. You can see the lingual flap before doing the displacement, it is 6 millimeters. After doing the displacement, it is 17. So imagine we displaced the lingual flap 11 millimeters. The preparation of the bone was done. Using bone scraper, we remove as much as we can of autogenous bone. The last implant standing also suffered from the infection that happened here. I tried to save it. I did some bone regeneration around it also while doing this regeneration. Membrane was stripped to perfect condition. The bone was placed, membrane stabilized from the lingual, everything closed, and I did some regeneration around this implant. This was my last try to save the last implant. Same kind of sutures, 9 months. This was before, this is after. When we see this image, we can actually see that probably we have bone, we gained bone. This is 9 months after. Now we can place 2 implants of 11.5 millimeter here. Everything we opened again. See the quantity of bone that we gained. So sometimes we have some connective tissue to remove from the crestal part, and the last implant was removed as we didn't gain bone. And I decided to place another implant, more lingually, smaller diameter, and to do another regeneration on it. 4 implants were placed in ideal position, suturing everything. So imagine, this was the picture before doing the graft, and this is after doing the graft. We practically gained everything we lost. That was before until now. Another case of a patient having a car accident. Car accident and trauma in the anterior mandible and maxilla are very often. So this patient, imagine he lost 6 teeth, and he had this big hole in this area. Vertical regeneration actually is indicated. The flap was opened. Same technique, same membrane. Bone placed, fixing the membrane, waiting for 9 months, and reopening. We gained, see here, the 12 millimeter vertical height loss, and now the gum is practically on the temporaries. Another case, also car accident. He had this big bone loss in this area, 5 millimeter vertical bone loss, and horizontally only 1 millimeter. Same technique, recipient site preparation, fixing the membrane from the lingual, placing the bone, closing everything, waiting for 9 months, reopening again. The bone is practically complete. 1 implant was placed to replace 2 lower incisor. We don't place 2 implants because the distance is too short. So this was before, and this is after. One of the most crucial areas, the anterior, the upper maxilla, especially if the patient has a gummy smile. So we have a gummy smile, and this patient came to me in this situation. We removed the temporaries, and we can actually guess what happened down. Also, it was a car accident. More complication. Another dentist tried to place implants in this apical position. Imagine a patient with gummy smile having a sentence that starts 7 millimeters more than the one next to it. So the treatment plan, actually, this is the x-rays, and these are the 3D. Even the implants that were placed in apical position, they didn't have bone on the buccal. So imagine where the bone is. The treatment plan consisted of removing the 2 implants, the extraction of 11, vertical and horizontal bone regeneration, crown lengthening for the other areas to remove the gummy smile, and doing prosthetic treatment after. So the first thing to do is the removal of the implants. That was done non-surgically with special devices. We removed the implants. We waited for 6 weeks until complete soft tissue healing, and we went again to do the bone grafting. Unfortunately, when we opened again, we saw that there was a big infection that was not practically that much visible on the x-ray, and we needed to do bone regeneration here next to an infected area. This is a high risk. If we do it, we can lose everything. We didn't take any chance. We didn't take any risks. So at this stage, we only removed the central incisor. We actually removed all the infection. We closed again, and we re-entered after 6 weeks. So it's our 3rd attempt. We re-entered. Everything was ready for vertical regeneration. We needed 12 millimeters vertically on the buccal and 6 millimeters on the palatal. Of course, we have to remove some autogenous bone from the ramus area. The membrane was fixed from the palatal side. The bone was placed in ideal position. Everything closed. Complete closure. And placing temporaries. This patient came to me, this is after 8 months, because she traveled, even though there is a lot of plaque, because actually she was afraid of brushing the area. She had a complex of not touching the area. But even though, we can see that the hole that existed in this area is gone. So, we removed the temporaries, we did crown lengthening on the 2 other sides, left and right. This is the bone that we actually obtained. This was before, and this is after. Practically complete regeneration. Crown lengthening, imagine the width of the bone also that we had, maybe 10 millimeters of width. Two implants were placed in ideal positions. And this is the temporary, and this is another set of temporary. What are our limitations? How much vertically can we go? Well, we don't know. Sometimes I challenge myself. I have some cases when I say it will not work and it works. Like in this case, imagine the bone loss that we have here. This is an implant failure. So the implants were removed. Imagine the mental foramina is here. It's actually maybe 1 millimeter below the crest. And I did the vertical regeneration, and this X-ray was taken some weeks ago. This is after 7 months. Everything actually is working. So until now, there are no limitations. How much far can we go? We really don't know. In the consensus report of the European Federation of Periodontology, done in 2019 and published in the Journal of Clinical Periodontology, they actually stated, because a lot of people ask me, how stable is the bone after doing the vertical regeneration? How much bone we will lose after that? The consensus actually gave answers to this, and they didn't see more than 1 millimeter of bone loss after 12 months. 1 millimeter is acceptable. This is why whenever we place implants after doing vertical ridge augmentation, we place the implant under the bone, 1 to 2 millimeters. And because we are preventing this bone remodeling that will happen from placing the implant outside the bone. And there are no complications of peri-implantitis more than any other implant. So for the vertical ridge augmentation, here they stated that it is a highly technique-sensitive surgical intervention and to be performed only by highly experienced clinicians. And I can tell you, after my 25 years of experience as a periodontist, this is one of the most difficult procedures that a dentist can do. It's really difficult. So, as a conclusion, they say that the evaluated bone augmentation procedures have proven to be effective to the reconstruction of the alveolar ridge defects. However, some procedures are really demanding and very high risk of post-operative complications. I would like to thank you for your presence. And this is my educational Instagram. If you are interested in seeing more cases, you can add me, _pro. And I'm ready for your answers.
Thank you, Dr. Naji, for this excellent presentation. We will take maximum 2 questions.
Thank you, Dr. Naji, for this precious lecture and the splendid iconography. I would like to ask for the mesh technique is a part of your private practice, and also for the lingual advancement flap. Is it for the lingual advancement flap to close the wound? Is it mandatory to use the blade 15 in zone 2, or is it feasible to do it only with a blunt instrument like a periosteel? Thank you.
Okay. The first question was about the mesh, yes. There are 2 kinds of mesh. You have the mesh that you buy from the companies, you trim it yourself and you place it. And you have now the new generation of mesh that can be actually fabricated after your CBCT by companies like Geistage, like Zimfi. They fabricate special mesh. Personally, I don't have any experience with those mesh, but I have experience with the other mesh. The other mesh actually, they are more difficult to trim during surgery, more difficult than the membrane, the titanium reinforced membrane. And the removal of this mesh after doing the grafting to place the implant is also more difficult. So it is more simple to use titanium reinforced non-resorbable membrane. Your second question was about the lingual displacement, how to do it with a Yes, actually, after my experience, I use it all. Sometimes I try with the 15, it doesn't go up. I try with the blunt instrument, it works. Sometimes I start with this one, it doesn't work, I go back to the blade. Sometimes I use other instruments like a small elevator. So it depends on the case. It depends on the patient, how much thick his gum is from the inside, how much thin it is, how much muscles he has. So use whatever you can, okay? But you have to displace the flap for a minimum of 1 centimeter.